I'll tell you about real quick is how do you present your patient? So now that you've seen your patient, you have your consults, you've done everything, how to present the patients. Again, this is based on when I started, I really didn't know how to fully present the patients really well. And one of the Tufts medical students, he he was nice enough to give me like a little talk about like how to present, and he wrote me a little paper. I remember I took a picture of it and I still use it. And this is just a kind of recapitulation of it. Okay. So how do you present the patient? Again, there's no right or wrong way of doing it. Everybody has their styles. The more you progress into your residency, the better you become, the more efficient, the faster you become. But as an intern, you're really expected to just kind of say everything. Okay. You're like a reporter and you're presenting to your attending with everything. And then finally, you might want to give your kind of 2 cents about it. But really, you're more of a reporter than the thinker when you start. But then slowly you become more and more like of thinking abilities. Okay, so let's go over it real quick. So what I'm writing here are the things you're going to say out loud. So these are the things that you're going to be saying when you're presenting your patient. Okay. So first of all, it depends whether this is a new patient or an old patient. For this purposes, I'm just going to focus on how to present your old patients. Okay. So when you're presenting your old patients, you're going to first present the one-liner about the patient, the whatever, small summary to remind the attending about this patient. A lot of times this could be a different attending, a new attending for you. You've never talked to them. They don't know these patients, but they usually have a sign out or they get a sign out about these patients. Okay, so you get you're going to say the one-liner. This is a 65-year-old gentleman who came to the hospital with blah, 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 and found to have a GI bleed. And now we're following for this. Okay. The next thing you want to talk about is mention the 24-hour events, whatever happens over the 24 hours. And usually what would be nice is for you to say these a problem by problem basis, which means like yesterday, you mentioned the plan from yesterday. Yesterday for the GI bleed, we consulted GI and they recommended PPI and an endoscopy. And then overnight, the patient was doing well. There's no signs of bleeding. Or like for his pneumonia, this is what we did, and this is what happened overnight. Otherwise, you can say the patient was stable overnight and no acute events happened overnight. Okay, a lot of people would summarize that as no acute overnight events, something like that. You might see something like that. Some of these abbreviations. Okay. So that's a 24 events. So again, you can go problem by problem, mention what was the plan from yesterday, and what happened with the plan or what happened to the patient overnight in terms of that thing. Most patients on the floor are not going to be that active. Most patients on the floor are going to be patient was stable overnight, no acute events. Sometimes something happens, okay? Hello, when you're in the ICU, again, it's the same kind of structure, but in the ICU, I put this in kind of, dashed lines because this is not patients on the floor. These are patients in the ICU. Usually, they will have, they will be either on a vent or they will be on pressors or they will be on sedation. So what you need to mention is, again, this warrants a whole lecture for itself about vent, sedation, and pressors. But for the vent, you want to mention when they were intubated, and you want to mention the vent settings. Okay, the vent settings. Again, it's a whole different lecture. It's a long talk, I think. But eventually, you're going to have to know them. Okay, you're going to have to know what are the vent settings that the patient is on. Okay, and then you're going to mention the sedation. What kind of sedation the patient is on? Is it propofol, Precedex? What kind of sedation they're on, and you also want to mention the pressors. And for the pressors and sedation, you want to mention whether things are going up or down, especially for pressors. For like if patient is on norepinephrine, you want to mention, is it trending up? Are we going up on the norepinephrine, or are we going down overnight on the norepinephrine? And what is the current dose? Okay, and then again on the floor and on the ICU, you want to mention the vitals. And what you want to talk about when you want to say out loud is not just the vitals now. You want to say the vitals over the 24-hour period, and you want to mention ranges. Like, for example, the systolic blood pressure was between 90 and 120, with diastolics between 40 and 80. with MAPS. You want to mention the MAPS as well, especially of compressors. MAP is the mean arterial pressure. You want to mention like the MAPS were from 60 to 75, for example. And then if somebody has a central line and you have a central venous reading, you want to mention that the CVP was 5 or ranged from 5 to 10 overnight. Okay. And then you're going to mention the respiratory rates, temperature, if they have febrile, if they're febrile, if they had fevers. Again, in terms of temperature, I don't know, we're all used to Celsius. A lot of people here use Fahrenheit. It might take some time to get used to, but you can still mention Celsius. You can still say patient temperature was 37.2. No one will fault you, okay? So you're gonna do the 24 hours, then gonna mention the now. What is the latest when you saw the patient? Plus, you're gonna mention your physical exam. On physical exam, this is what I saw. Pertinent positives, pertinent negatives. Don't mention everything, okay? Don't mention, oh, the neuro exam was normal when the patient has pneumonia. Like, unless there's a pertinent negative there, it really can be a waste of time, okay? So very important. And then this is kind of, again, mainly for ICU, lines, tubes, and drains. Like if they have a central line, if they have an arterial line, if they have the endotracheal tube, they have a nasogastric tube, and then drains if you put in any drains, okay? The most important one actually to mention here on the floor is the Foley, okay? Is when was the Foley placed? Okay, the day of the Foley, and what's the plan with it? Like it was removed, it was replaced, or something like that, okay? The reason is because the hospitals, there's a big quality metrics on the hospitals to get rid of Foleys as soon as possible. And there's a big quality metric about Foley associated or catheter associated UTIs. So they call them catheter associated UTI, CAUTI. And this is like a big quality improvement. So they follow these things very closely, okay? And then finally, you know, you want to mention the eyes and nose. This is something, I don't know, we're not used to. I wasn't used to when I came here. And how do you actually mention the eyes and nose? You really want to mention the inputs, how much the intake, how much the patient gotten in terms of fluids, in terms of PO intake. And this is all kind of recorded depending on your electronic medical record. Epic makes it easy. Some others makes it a little difficult. You have to kind of calculate yourself how much input was the patient got and how much output in terms of urine output, anything else, okay? And then the urine output, usually the normal urine output, you really want to have it as, you know, this magic number. Anything above this is good, 0.5 cc per kg per hour. The patient is 70 kilogram, 100 kilogram, then, you know, 50 cc per hour is enough. So you calculate it over a day, 1.2 liters per day is good enough, okay? So that's the way you want to think about it. And then you also want to mention kind of the net. So is it net negative or net positive, the patient? The patient is net negative 1 liter. The patient is net positive 2 liters. This will give you an idea of how much, you know, fluids the patient needs or needs to be taken care of. And then you're gonna mention the pertinent medications. And then here, one of the most pertinent medications is antibiotics. And plus you want to mention this is day X out of Y of antibiotics. Like this is day 2 out of 14 of ceftriaxone, for example. And then plus all the other medications that you think are pertinent. You don't need to mention like the home medication or stuff like that. You really need to mention the pertinent. Again, when you start as an intern, when you're not very efficient, you might mention everything, but you can just mention the pertinent ones. And then you're going to talk about labs. Again, the labs are going to be either the pertinent ones, and really the most important is today's labs. You know, today's labs and the pertinence of today's labs. If there's a trend, for example, if you say like creatinine today is 1.2, you want to mention what it was yesterday, like yesterday was 1.4, then you know it's downtrending. Or white count is today 12, yesterday was 7, so it's uptrending. So you need to mention kind of the trends. Okay, very important. And then in terms of micro, remember when you're mentioning micro, you can say like blood cultures are negative, but you also want to say since when. A lot of times they will be, you will see a thing called blood cultures NTD, negative to date. Okay, so this is important for you to kind of figure out. Like the reason they write negative to date is because it might grow later on. Sometimes they incubate them for 5 days and then they say it's negative, final negative. So you need to say this culture is negative for 2 days now, because it still can grow something. All right. And then finally, you want to mention the imaging. Again, when you mention the imaging, you're going to mention the radiologist impression about the imaging, like whatever the radiologist thought about the image, no cardiopulmonary disease, normal. And if you want to take an extra step, you can mention that you saw the image itself, you saw the actual X-ray, and you know what you think of it. Okay, and then you know what exactly is your thought process about it. Like, yeah, I think the radiologist said this, but I don't know, I see like an opacity, can we look at it? And then what happens is your attending might open the image and go over it with you and tell you, oh, this is what's happening. And this is how you learn, okay? Again, remember, oh, my thing crashed. Again, remember when you're doing these things, okay, you are really, you know, you are expected to make mistakes, okay? Don't be afraid to make mistakes, because everybody knows that you're starting as an intern. Everybody knows that you don't know everything. You're not used to the system. This is all new. And so you're expected to make mistakes, just not recurrent mistakes. That's the idea. Learn from these mistakes. Okay, so if you make a mistake while reading an X-ray, you can adjust it. Or if you get some feedback at the end of the day, or your resident or your attending tells you have to do something in a different way, you really just have to learn from this mistake. Okay, we all make mistakes. Attendings still make mistakes. Everybody does. But the difference between somebody who improves and somebody who doesn't improve is those who improve, they learn from these mistakes. Okay, so you really have to keep that in mind. Okay, and then, you know, finally, what ends up happening is that after you do all this is all just your presentation, then you're gonna go as a team and you're gonna see the patient finally in the room, you know. Some people do it differently, but this is the common theme. So after you see the patient in the room as a team, then you're gonna come out and then you're gonna continue the rest of your presentation. And what is the rest of your presentation? The rest of your presentation is the assessment and plan. Okay, so you're gonna say your assessment about what's happening with the patient, and then what is the plan, problem by problem. So you're gonna go problem number 1, GI bleed, blah, blah, blah. And then problem number 2, this is what we're doing. And then you're gonna kind of mention everything. And then finally, don't forget the, you know, FIN PCD that we talked about in the note, in the admission note. So you know, you want to mention the fluids, the fluids, electrolytes, nutrition, prophylaxis, code status, and then finally the disposition of the patient. Where is the patient going at the end of this? Okay. And again, this is really the most important and the most difficult part. You as an intern, it's easy to do all these on the left side. Here on the left side are the easy stuff, because this is all just kind of regurgitating events, regurgitating things that are already in the chart. But here is really the synthesis part on your behalf. You have to think about what to say and how to present these patients. Okay, cool.